When the mind begins to fail, the subjective experience is often one of total disorientation. Situational awareness and long-term memories begin to fragment, leaving the patient unable to anchor themselves in time or place. At the bedside, this failure presents a massive clinical challenge. On the surface, different cognitive disorders look nearly identical, presenting with a shared set of symptoms: confusion, agitation, and profound memory loss. Distinguishing between these states requires evaluating three specific clinical axes: the timeline of the onset, the structural integrity of the brain tissue, and the functional specificity of the cognitive deficits. By analyzing these variables, we categorize cognitive failure into three distinct categories: delirium, dementia, and amnesia. Accurate differential diagnosis is the foundation of patient management. Identifying the correct category determines whether a medical team attempts to reverse a systemic crisis, manage a progressive structural decline, or address an isolated psychological trauma. Delirium is an acute syndrome. Unlike chronic conditions, it develops rapidly, over mere hours or days. This results in a severely diminished awareness of the environment, manifesting as a fluctuating inability to maintain or shift attention. The most important prognostic factor of delirium is that it is a syndrome, not a structural disease. It is typically transient and reversible once the medical team addresses the underlying physiological trigger. Clinicians use the pinch-me mnemonic as a diagnostic checklist. This helps identify the systemic physiological stressors that typically trigger delirium in patients with a compromised mental status. The first 4 letters represent direct bodily distress, such as pain, infection, constipation or urinary retention, and hydration issues. Each of these can disrupt the brain's chemical balance and induce acute confusion. The remaining triggers include chemical and environmental factors, such as reactions to medications or abrupt changes to the immediate surroundings. Delirium effectively functions as a systemic alarm bell. Treating it requires the clinician to look past the brain and investigate the underlying bodily crisis causing the cognitive static. Dementia follows a different timeline. This comparative table shows dementia is defined by an insidious onset and gradual deterioration. Unlike the immediate attention deficits seen in delirium, a dementia patient's awareness and attention span remain clear and intact until advanced stages. This difference in presentation exists because the pathology of dementia is rooted in permanent structural changes occurring within the physical tissue of the brain. These changes are categorized geographically. Depending on which regions are compromised, whether the outer cortical region or the deeper subcortical region, different cognitive domains will begin to fail. Because dementia represents physical, structural deterioration, the clinical strategy shifts. The goal moves from the rapid reversal attempted in delirium to long-term symptom mitigation and management. Alzheimer's disease is the most prevalent form of irreversible dementia. It's a progressive disorder characterized by the destruction of neuronal connections essential for memory. Microscopically, abnormal amyloid plaques and tangled tau fibers form inside the brain. These choke the neurons, eventually causing cellular death and network failure. This cellular damage typically begins in the hippocampus, the region essential for forming new memories, before spreading globally across the brain. These PET scans show the physiological consequence of this damage. The healthy brain on the left shows high metabolic activity, while the blue and black areas in the right image indicate severe losses in activity resulting from the disease. As neurons die, physical brain tissue shrinks significantly. The advanced Alzheimer's brain shows widened surface gaps and drastically enlarged central ventricles. These visual proofs of physical decay cement Alzheimer's as a state of structural collapse, fundamentally separating it from the transient confusion of delirium. Amnesia is defined strictly as the loss of facts, information, and experiences. It is distinct from dementia because it typically occurs without a broad decline in executive cognition or daily functioning. Organic amnesia follows 2 temporal vectors. Retrograde amnesia is the impaired recall of past events, while anterograde amnesia is the impaired ability to learn and encode new information moving forward. In some cases, patients experience transient global amnesia, or TGA. This is a sudden, hours-long block where new memories cannot be made, likely triggered by acute vascular flow abnormalities or hypoxia. Memory loss can also be psychogenic. Dissociative amnesia is driven by extreme stress or psychological trauma. These memory gaps have distinct boundaries. Localized amnesia involves losing a specific traumatic block of time, while continuous amnesia involves an ongoing failure to encode new traumatic events. Because amnesia, whether vascular or psychogenic, is an isolated deficit, it requires targeted neurological or psychiatric intervention, completely separate from global dementia protocols. The success of clinical care depends on sorting these overlapping symptoms into their correct pathophysiological categories. The delirium profile is defined by a sudden onset and heavily fluctuating attention. When this appears, the clinician must hunt for the underlying systemic medical stressor. The profile for dementia is defined by an insidious onset, initially preserved attention, and evidence of progressive, irreversible structural decline in the brain tissue. Amnesia represents an isolated gap in memory encoding or retrieval, occurring while the patient's general daily functioning remains largely intact. Accurate bedside differentiation is the foundation of patient outcomes. By identifying these patterns, the clinician determines whether they are reversing an acute crisis, managing a structural decline, or addressing an isolated trauma.